As you would, the last two sessions were directed at one on epidemiology of thalassemia, and second was on transfusion therapy in thalassemia. Now, in this session, we address a very important topic, which is blood safety, especially important for low and middle income countries that face the entire burden of viral hepatitis and transfusion transmitted infections. So to discuss this, today we have two esteemed speakers, Professor Erica Wood, who is joining us from Monash, and Professor Arashma from PGI Chandigarh. So today, for this, we will not project the slide today. No? I will introduce the speaker later, Paramita. Just keep the first slide on. So to set the context, it's my honor to invite Shobha Tuli ma'am. Ma'am is the secretary and the founder of Thalassemics India. And she's also currently the secretary of Thalassemia and board member of Thalassemia International Federation. Over to you, ma'am, for discussing the context of this topic before we go ahead.
Thank you very much, Neeta. So on behalf, good evening to all of you. And of course, in Australia, I think it's good morning. So good morning to Dr. Erica. On behalf of Thalassemia India and Thalassemia International Federation as well, because Dr. Enrula Alfitrio hasn't joined yet. She may join later on. I once again welcome you to the third session of blood safety. And as earlier said, that this session is very, very important because it's going to talk about the blood safety, the blood availability, and the blood accessibility. And it's our privilege and honor that we are going to have discussions and to hear from the experts, the global experts, Dr. Erica Wood and Dr. R.R. Sharma about the Indian scenario. And I'm very sure that our speakers and the chairpersons would be touching upon the real issues that really that we see in day-to-day life of our thalassemia patients, which is the blood safety, the most important thing, as well as the blood availability and accessibility also. Sometimes, we all know about the scenario, but we don't have the solutions to that. I have some few figures as far as Delhi is concerned. So in Delhi, in a year, 5,46,016 units were collected. Out of that, the voluntary collection is only 2,43,000, and the others are the replacement donors. So this is something which is very concerning to a countries like low income and middle income group also. And that in our country, in India, we have, which Dr. Sharma will be talking about, we have over 4,000 blood banks, but out of them, the more numbers are of the private blood banks. So whereas we feel that what we understand is that there's no uniformity of the parameters that they have to follow in the private blood bank. So I think that all our speakers and the chairperson would be highlighting and coming up with some solutions so that we can see that we also improve the blood scenario in our country as compared to the other advanced countries. Thank you very much. So I hand it over to the organizers, please.
Thank you, ma'am, for bringing that important statistic also. So here again, we also constantly document. So we work in a government institute in UP, which is Noida, and we constantly see. So although the provision for testing as well as the provision for entire thalassemia care comes under the National Health Mission, the blood cell of the National Health Mission, and there is provision for each and every district of the state of UP. I'm sure that is the case in most other states of our country. We still have a lot of heterogeneity in care. So without any exaggeration, 1 out of 3 patients who are coming in from many districts in UP for an opinion or for just routine workup, for calculation, etc., they're getting transfused locally. 1 out of 3 patients are now Hep C positive. And this is a data we are collating and we are about to publish that as well soon. So this is the kind of patient, or almost 30% of patients who are multiply transfused are Hep C positive. And that's the staggering numbers of patients that we are to treat. So it's only a small relief that the treatment of hepatitis C is now available through the government, and because of which patient does not have to pay for that treatment or for the RNA testing. But still, it's a huge burden of disease that we are looking at. So to discuss this further, I would invite the moderator for today's session, Dr. Satyam Arora. Dr. Satyam is additional professor in the Department of Transfusion Medicine at our institute, Postgraduate Institute of Child Health, Noida. Welcome, Dr. Satyam, and I would request you to introduce the speakers and take the session forward.
Thank you, Dr. Neeta. And before I begin, I would like to thank everyone to, find time and be available for our webinar. This has been discussed by Dr. Tuli as well, that it is a topic that is still very challenging for managing thalassemics in low and middle income country. Even when we're moving ahead with better therapies and better care for our thalassemic patient, this TTI is still an unresolved issue, and many blood centers are working very hard to provide safest possible blood, but there is still a lot of variation the way blood is tested, it is collected and processed, even in a big country like India. And today, to discuss this more, we have two eminent speakers with us. And the first speaker is Professor Erica Woods, and she will be discussing what is the global scenario of the availability, testing, and screening of blood, and how that is different from what we practice in countries in low and middle income countries. And may I just request to project the slide to introduce Dr. Erica? So she's professor. She's head in transfusion research unit at Monash University in Melbourne, Australia. She's a consultant hematologist at Monash Health. She's a chief investigator at Blood Synergy Program. She's very actively involved in various international groups and have been the president of International Society of Blood Transfusion, International Hemovigilance Network, Australia and New Zealand Society of Blood Transfusion. She is presently co-chair of the WHO Advisory Group on Blood Regulation, Availability and Safety. She is presently chair of TGA Advisory Committee on Biologicals and chair of the National Hemovigilance Advisory Committee. She's been a former chief examiner in hematology at Royal College of Pathologists of Australia. She's a founder member of Blood Matters Transfusion Practice Improvement Collaborative, and she's awarded with many laurels, and very recently in 2003 with the Distinguished Services to Hematology and Transfusion Medicine. And it's been a pleasure for me as well that we have worked closely at ISBT. And thank you, Dr. Rika, for accepting our invitation. We really look forward to your talk today in the evening, and I hope with the knowledge and with your experience working globally, you will be able to bring in a lot of interesting facts to our audience today. So now may I request Dr. Erica to kindly share her screen and present.
Thank you. Thank you very much for the kind introduction. It's really a pleasure to be here. I'll just check if you can see my screen. I'll proceed with the presentation, just also checking you can hear me.
Yes, we can see the screen, ma'am.
Super. Thank you very much. So it really is a pleasure to join you to talk about this important topic. I'm a clinical and laboratory hematologist, and I work at a large hospital, a large academic hospital in Melbourne, which happens to be our thalassemia referral centre for our state. But my main focus is on blood transfusion, and I'll talk about some of these aspects in my presentation, share a few resources which I hope will be helpful, and look forward to participating in the discussion. So let's start by thinking about the universe of safe and appropriate transfusion practice. So really, you can summarize this as achieving the right blood to the right patient at the right time, for the right reason, and with the right outcomes. So that should be pretty easy. I think the fact that we are having this webinar reminds us that it is not easy. So if we try to break this down a little bit more and with a focus on the safety aspects, which we'll explore more today, we need thinking, what is the right blood? Well, firstly, it needs to be safe, or as safe as we can make it. We recognize that there are many infectious and non-infectious threats to the safety of the product. We also need to make sure we have the right product type. If the patient needs red cells for oxygen carrying capacity, but they don't need volume, then red cells will be a much more appropriate product than whole blood, for example. We need to think about the patient's specific needs. What does this person need under these circumstances? And we'll come back and talk about that in more detail in a few slides. We also need to have the right donor. Many aspects of transfusion practice absolutely depend on, for example, matching the donor to the patient's needs. And we'll talk about that a little bit more. But also, this blood needs to be available. If it's not available, then we are really in a lot of trouble. What about the right patient? I've put some little icons here of different patients. Obviously, we have everything from antenatal care and tiny neonates all across the lifespan to patients who are elderly. And many of our patients with thalassemia, of course, are now living much longer thanks to advances in care. So we have more older people with thalassemia, and we need to make sure that they are taken care of at all stages of their life, including here from childhood, young adult life, pregnancy, and to older life too. When we think about the process of getting the blood to the right patient, I'd like to talk a little bit later about how the patient can and should be involved in their transfusion care. And this can be a very important part of blood safety. In order to make sure we get the blood to the right patient, we need to make sure that they are properly identified. And failure to do this is an important safety hazard in the transfusion process. We need to have this blood available at the right time. So blood centers and hospitals invest a lot in having the blood available. We have to bear in mind the shelf life of these products. They all have a finite shelf life. We need to get them from where they are collected, which in some places may be in the same building, but in many places could be hours or hundreds of miles away. So the logistics of these often short shelf products become very complicated. We also need to bear in mind the costs. So the costs of having a safe and adequate blood supply are very substantial indeed, and we need to think about who bears these costs. In many countries, including my own, there is no direct charge to the patient who needs a blood transfusion, and the community bears these costs. But that is not the case in every country. And what about the right reason? Are we clear on the clinical indication? For patients with thalassemia, usually this is not controversial. But many other patients who also receive transfusion, it might be less clear. For example, if the patient has iron deficiency, then rather than giving that person a transfusion of red cells, unless they are extremely symptomatic, could they not be better off treated with oral or intravenous iron therapy? So we need to think about alternatives to transfusion where these exist. And of course, in the thalassemia setting, there is a huge international research program to try to find therapeutics that will minimize the need for transfusion requirements. And if the reason for transfusion is not right, then no risk is worth it to the patient. So we need to take this into account on every occasion. And we need to make sure that there will be people available to monitor the patient and take action if there's any sign of an adverse event. And then we need to think about the right outcomes. So historically, we've often been very simplistic about the outcomes of transfusion that we measure. So for example, if we give somebody a red cell transfusion, we often think that the outcome is that their hemoglobin goes up. Well, that is one outcome, but it's not a very patient-centered outcome. Is the person less breathless? Have they got more energy? Can they walk upstairs? Can they do shopping? Can they go to school? These are all important clinical outcomes that we need to bear in mind when we're talking about transfusion safety and outcomes. So in the introduction, there were already some words about the very, very challenging international situation in terms of availability of blood and the safety of that blood. So WHO every few years publishes a global status report on blood safety and availability. The most recent one that has been published is from 2021, and some of the data are from several years earlier than that. So we should understand these caveats when we read these reports. We also need to understand that some countries are not able to contribute any data or accurate data to these reports. Here's one example from that most recent report about blood donation and population here on the left in the different WHO regions. And you can see here, for example, in the Southeast Asian region, the African region, over on the extreme left, you can see the disconnect between the number of donations and the number of populations, the number of population here in all three of those cases on regions on the left-hand side of the graphic. You can see that there is a disconnect between the population and the availability of donations. On the right, this is presented by income per capita in the country, and you can see here that in high-income countries, there are high levels of donation in relative to the population, but that is not the case for low-income and lower middle-income countries. So we have enormous challenges here, and I know that you're very aware of this in India, of course. In order to have safe blood, we also wish the blood to be donated by volunteers who are low risk and who are truly donating voluntarily to help somebody out of altruism. Notwithstanding all of the caveats I mentioned about the availability and quality of data in the report, you can see here that at least at the time of last report, there were many countries where only a proportion of donations were provided by community volunteers. So there's a lot of work to do here all around the world. And then, as I mentioned in an earlier slide, we need to have the right kind of blood component to meet the patient's needs. And in the thalassemia setting, we're predominantly talking about red cells. You can see here on this slide, however, that in many countries, there is a low proportion of separation of blood, whole blood, into its components. This is particularly low in the African region, but there are quite a number of other regions here where less than 50% of whole blood is prepared into blood components like red cells. And you contrast that to Europe, for example, where nearly all blood donations are separated into components. Fortunately, some of this is changing rapidly, but not rapidly enough. There are other resources from WHO to help tackle these issues, and this is just one that I wanted to mention. Many of you may already be familiar with it, but addressing some of the issues and ideas and practical approaches for how to increase voluntary non-remunerated blood donations in the Southeast Asian region. And if you haven't seen this report, I'd recommend it to you. So to come back to these, some of these safety issues, we often talk about vein-to-vein pictures of blood donation, and here we are really thinking about the safety issues. And you can see here on the left, we've got the blood donor, then we've got their donation and the donation process, preparing a product in a blood center, all the hospital processes, and of course, taking care of the patient around informed consent, the transfusion process, and ideally, an excellent clinical outcome for the patient. Underpinning this, and something that I would like to talk about a little bit in the next few minutes, is the concept of hemovigilance, which I'll define on a subsequent slide. And we're really thinking here about the donor's safety, the patient's safety, and the safety in the broader community, as was mentioned in the introduction. So hemovigilance, in many people's mind, focuses on the patient's safety. And of course, the patient is the reason that we are putting in all of this work to try and make blood available. But if we don't bear in mind the donor's safety and the broader community safety, then we are really missing the big picture. In order to understand the safety and availability of blood in our country, we really need data. And data in many ways historically have been difficult to come by, as I was just saying about some of the WHO reports. But increasingly in an electronic age, we will have more data, and we need to think about the quality and accessibility of these data. So for example, about donors, the donations and the products, we'll be able to think about blood service data. For the hospital processes and the patient management and the clinical outcomes, increasingly electronic medical records and laboratory information system data, and clinical coding data. For example, how long did the patient stay in the hospital? Did they need intensive care support? These kinds of data can be very valuable. Of course, we have hemovigilance data where these exist, and I'd like to congratulate India for the enormous hard work that's gone into developing a national hemovigilance program in your country. Then there are many other data sets that can be helpful to us, other public health and other vigilance data. So pharmacovigilance in some countries, blood components and blood products such as fractionated products are managed under pharmacovigilance. And there are many lessons for us about other cellular therapies or biovigilance that we have in common with blood. Many government data sets, such as utilization of healthcare resources, hospitals, pharmaceuticals, may be helpful. Insurance data sets, health insurance data sets, industry data can be very valuable when we think about the equipment that we use to collect, prepare, and transfuse blood products, cell salvage devices, apheresis machines, etc. There are many research data sets that we can also incorporate into our understanding of vein-to-vein safety. But historically, the point I would like to make is that really many of these data sets have not in any way been linked or analysed to give us a total picture of blood safety. But increasingly, we now have the tools to both rapidly access, link, analyse and share data, and while doing this in a secure way that maintains the confidentiality of the patient data. So let's think a little bit more about where this all started, and thanks to everyone who's a blood donor, and on World Blood Donor Day on the 14th of June, we particularly celebrate these blood donors and their vital gifts. And the 14th of June, which is World Blood Donor Day, is also Karl Landsteiner's birthday. And of course, we know Karl Landsteiner is very famous for discovering the ABO blood groups back in 1901, which was an absolutely foundational piece of work without which we couldn't provide safe blood. And this is a slightly corny or cheesy, but a very interesting website called scienceheroes.com. And there's a league table of who saved the most lives in history. And here you can see here Karl Landsteiner and also Richard Lewison, who developed blood storage solutions leading to the ability to provide safe blood transfusions. And you can see here the enormous numbers of lives that have been saved by blood transfusion. But we also know that terrible consequences can occur through adverse events such as transfusion-transmitted infections, but also other immunological and other types of reactions. So in Karl Landsteiner's Nobel Prize acceptance speech, he said that in 1930, all in all, the results of blood transfusions were already highly satisfactory in his view. And he said that we have reason to hope that a thorough study of cases with undesirable after effects will help us assess the causes and perhaps reveal unknown causes, and finally virtually eliminate the slight risks which transfusion still involves. So I think he was definitely an optimist, but I also like to think that he is the father of hemovigilance. So what is hemovigilance? The International Hemovigilance Network describes this as a set of surveillance procedures or a surveillance system covering the whole transfusion chain, intended to collect and assess information on unexpected or undesirable effects resulting from the therapeutic use of blood and to prevent their occurrence or recurrence. There are slightly different definitions in use around the world, but this is a very broad one. And a lot of hemovigilance stems from the infectious risks to the blood supply. This was a nice review published several years ago now, but a really excellent primer in thinking about some of the infectious risks to the blood supply. It has a North American focus, and you can see in the top of this. Hello?
Yeah, please continue.
Thank you. In the top of this image, this is a logarithmic scale looking at the rates of hepatitis B, C, and HIV in the blood supply in North America over some decades, which are across the bottom of the screen. You can see here the measures that the United States took to try to improve testing for some of these agents, and of course, additional tests have been introduced since that time. And you can see here this huge list of infectious threats to the blood supply. And the message really from this is about vigilance for emerging infectious diseases. But a great deal has been achieved in reducing infectious threats in high-income countries. Building on that important safety improvement, there's been now much more attention to focus on the patient and how we deliver care to the patient. So I've mentioned the importance of patient involvement and patient-centered care, and I'd like to spend a few minutes talking about patient blood management, as well as the importance of oversight and governance of our practice, for example, having transfusion committees, policies, national standards, and clinical practice guidelines, and a few more words about hemovigilance. And this is a friend and colleague and a patient at the hospital where I work, and he serves on our hospital transfusion committee, and he has thalassemia, and so we see him regularly for a blood transfusion. And I use these photos with his permission and encouragement. And I'd like to really pursue this theme for a couple of minutes, because at the end of the day, all transfusion is personal. So I think it helps to think about individual people and their circumstances when we are thinking about blood safety. So some of you will know about the UK Infected Blood Inquiry, which handed down its report only a couple of months ago. And here is an image of the wife and daughter of a man who was infected with a transfusion-transmitted infection decades ago and who has since died. And there's not time to discuss in detail the findings of the report, but there were a number of very major recommendations taking into account the consequences for patients and their families of receiving infected blood. So the government has acknowledged the report and committed to implementing the recommendations, including an apology and compensation. And there are lessons for us in other countries all around the world about how we communicate with our patients. How do we tell people what we know when we know it about transfusion safety? How we focus and work hard to achieve a safety culture, not just the safety of the blood, but how we use it, how we can prevent future harm, how we will implement the recommendations of what we learned through hemovigilance. And importantly, and I thought this was going to be difficult to do, but very important to say, the inquiry recommended documenting the outcome, not just if the hemoglobin goes up, but what was the outcome for the patient of every transfusion. We are certainly not doing that in Australia at this time, and I suspect in many of your hospitals either. So what can we learn from hemovigilance? The UK also has one of the best hemovigilance programs in the world, and we won't have time to go through this in detail. But for people who are not familiar with the annual Serious Hazards of Transfusion report or SHOT report, you can see here, and I'm sorry, I meant to update this slide and I forgot, but there's a report issued every year in July. You can see here on the right-hand side that in the bottom section of that slide, that the most common adverse events reported to SHOT were not transfusion-transmitted infections. They were things like incorrect blood component transfused, giving the blood to the wrong patient, or giving the patient blood that did not meet their particular needs. And almost all of these cases were adverse events due to errors. You can see here that the number of errors which were thought to be preventable, and a smaller number which were possibly preventable. So why do we make all these errors in transfusion? So, you know, are people not trained properly, or are they not paying attention? Well, there are issues with training and attention. Life is very complex in the hospital setting. But I show this process map, which is part of some health economic studies we conducted in the setting of delivering a red cell unit to a patient with thalassemia major at my hospital. And you can see here, you don't have to take in every step, but just the number of steps to collect a phlebotomy sample for pre-transfusion testing from a patient. Many small steps. And so if we think of the weak link in the chain analogy, we can see how easily there could be a problem at any stage. So we need to think about how we can make our systems, our clinical systems, safer and more resilient so that the process is smoother and safer and ideally more standardized. And so that's just one process. But this next process map in the blue diamonds, it shows how each process interacts potentially with multiple other processes to deliver a transfusion to a patient down here at the bottom. So I think it really reminds us how complex our systems are and how we need to focus on designing safer systems so that patients will be protected. So I may be running a little bit over time. So Satyan, please stop me if when I need to stop, or give me a 5-minute warning. I'd like to spend a few moments, if I may, speaking about patient blood management. So patient blood management, and many of you will be familiar with patient blood management, but it's an evidence-based, multidisciplinary approach aimed at optimizing the care of patients who might need transfusion. And it puts the patient at the heart of decisions made around transfusion, promoting appropriate use of blood and the timely use of alternatives where these are available. So, for example, the history of PBM, a lot of it stems in the elective surgical setting, so things like minimizing blood loss are very important. And PBM is important for example, those patients who might be able to avoid a transfusion, but it also means that it can reduce allogeneic blood transfusions in some settings while ensuring that blood components can be available for patients who really need them. And so in this regard, it represents an international initiative in best practice for transfusion medicine. So this 3 pillars model of patient blood management is widely known and understood. And as I said, it really focuses on the elective surgical procedure, or at least the surgical setting where patients might be bleeding, for example, and we might need to improve our surgical or anesthetic techniques. And for reasons of time, we won't dwell on this. But what I wanted to say is that I think PBM is actually vitally important in taking care of patients with thalassemia. So we need to think, what is the optimal transfusion support management for this patient? Do they need a transfusion? Are there alternatives? And if they need a transfusion, how is it best delivered and evaluated? So this was a little graphic that we put together in a different setting, thinking about patients with myelodysplasia, but it applies equally well in the thalassemia setting. On the left-hand side, we have a group of pre-transfusion considerations. What are the patient's symptoms? What are their values and preferences? What comorbidities do they have, and what is their performance status? What laboratory results do we have or need? And are there any alternatives? If we proceed with a transfusion, we have to select the right product, we have to properly administer it and monitor the patient. So we need trained staff in appropriate location. And we need to make sure that there is adverse event recognition and reporting in place. So this feeds into hemovigilance. And then we need to think about evaluating the outcome of that and every transfusion. What happened to the patient's symptoms? Are they improved? Can we measure their health-related quality of life? Are their functional outcomes improved? As I mentioned before, can they do their shopping? Can they walk upstairs? Are they less breathless? And we need to bear in mind important long-term complications such as iron overload, which is vital in our patient group that we're talking about today.
Ma'am, 5 more minutes.
Thank you so much. So I think in the interest of time, I'm going to step over a few aspects of some slides, but I'm happy to make these available. So one thing I would like to suggest is that we need to have safer, more personalized transfusion therapy. So in our hospital, for all hematology patients, we now require every patient to have a transfusion management plan that is personal to them. We need to think about targeted product support. How can we have better matched products and make sure that the patient gets exactly what they need? And with research, we might be able to better predict when someone needs a transfusion based on their symptoms. And new tools are now, of course, becoming available for us to be providing much better matched products for people who need them. And genotyping is now much more widely available, not available everywhere, of course, but for patients and for donors. So I'm going to just skip over a number of slides to come to a couple of words about involving patients and families. And we were thinking back to that very complex process I mentioned before, thinking, where can patients be more involved in improving blood safety? Well, patients can be involved in the discussion around whether a transfusion is needed and, of course, informed so that they can provide informed consent. Patients can ensure that they are properly identified at the time of taking blood samples, at the time of transfusion identity check, during the administration of the product, and recording the outcome of the transfusion. And of course, patients need to be informed about how to respond if they have any symptoms of an adverse reaction. In Australia, we have directives that patients must and should be involved in improving the quality of care at the level of their own care, at the level of a service, and of course, at the level of an institution. So there's a lot more work that we can do and make sure that patients really are part of their own transfusion care and improving the care for other people. So I'll just skip ahead and say that there are also many resources available for how to inform patients and how to engage them in improving transfusion safety. I'd like to make a tiny plug for transfusion practitioners. In Australia, these are mostly transfusion nurses who have really changed the way we practice in the hospital setting and in the blood centre. And importantly, they are very much involved in adverse reaction investigation and haemovigilance. So I've mentioned WHO. There are a number of resources from WHO that are available. I'd encourage you to have a look at the AIDS memoir, which are very helpful for showing senior management and ministries of health. There are a number of clinical use of blood modules that have some very valuable information, including on blood safety and on patient blood management. And these are all freely available on the ISBT website. I'll just finish with a word about ISBT because that was mentioned in the introduction to my presentation. If you're not a member of ISBT, you'd be very welcome to join. We have a number of working parties relevant to the topic today, including clinical transfusion, which has a hemoglobinopathy subgroup. Our chair, Satya Maror, is a member of this leadership group. And the Working Party is currently running a survey, and I'll put the link in the chat. So we'd love your input on resources for transfusion in low and middle income countries. We have a haemovigilance working party open to members of ISBT interested in haemovigilance, and we hold congresses where we can exchange educational and scientific aspects. The International Haemovigilance, India is a member of the International Haemovigilance Network. We can talk more about this in the questions if there's time. And I'd like to thank all of my colleagues and the many people whose work I've mentioned today. Thank you very much for your attention, and I'm happy to take any questions later. Thank you.
Thank you, Dr. Erica, for this very lucid presentation. Not only, talking about the TTI, but also the patient blood management part. And I think it's as far as thalassemia is concerned, patient blood management is often a very nascent topic and it's not been addressed appropriately. And I think your presentation does give us a peek that, that is an area which we can work towards a holistic improvement of our transfusion recipients. Now we move ahead with our second speaker. I'll request the ECHO team to kindly project the slide for the introduction of Dr. R. Sharma. So, Sir is Professor and Head of Transfusion Medicine Department at PGI Chandigarh, and Sir has been my mentor and teacher. So it's always a pleasure to have him with us for all the academic activities that we do. Sir has a vast experience of more than 25 years in teaching and training people in transfusion medicine. He's been part of the MD curriculum development at many institutes. He's a recipient of the Advanced Active Therapeutic Apheresis Program and Advancing Apheresis Technology Award. He's received many prestigious awards nationally, both J.R. Jolly and H.T. Shaurya Award, as well as international awards. Sir has an extensive training in cell and gene therapy at University of Minnesota in US, and that was through the ICMR in India. Sir is part of the many big committees like Standing Academic Committee and Ethics Committee with ISBT, WHO Group on Blood Regulation and Availability. Sir is Secretary of the Indian Society of Transfusion Medicine, and he's an avid researcher with more than 150 national and international publications. Thank you, sir, for accepting our invitation, and we look forward to your presentation of the scenario of blood safety in India, as it's still an unresolved issue, and we all from the transfusion medicine side are working hard to provide the safest possible blood.
Yeah, thank you, Satyam, and good evening, everyone. And thanks for the organizer for giving me this opportunity to be here.
Echo team, please remove the slide. Yeah, so sir can share. Yeah.
Yeah. So yeah, this was. Are my slides visible?
Yes, sir.
Yes.
Okay, thank you. So yeah, so I think this talk when I started, so it was I thought that it will be quite easy, but it was really a difficult task after Ereka has covered the global perspective and touched various aspects of transfusion safety. So I thought that if when I start safety as blood safety in Indian perspective, I thought that let us look into the safety, how it started, how the blood transfusion services or the safety initiatives started in our country, and how these have evolved over time, and what is the current scenario, especially with respect to multi-transfused thalassemic children. So this is how I'm going to cover my talk. And if you look at this building, I think this is still there with some modifications. This is the Tropical School of Medicine in Calcutta, where I think it was Professor Lieutenant Colonel Lloyd, who was an imperial serologist who started a transfusion service in 1924. And if you look at this publication, this was from Indian Medical Gazette. At that point of time, I think there were no official journals, scientific journals in the country to publish regarding transfusion. So I think this was published about some discrepancies between the donor and the recipient. So, and this is how the laboratory looked like. And I think it was for a medical legal blood test, as the legend says. So another clipping, I think, which I got from this gadget was of 1942, where they said that they mentioned that the Lloyd started this transfusion services, and it was realized that transfusion is an emergency, and inevitable delay in obtaining a donor could result in a disaster. So they thought that if it is collected aseptically, it can be cool, because as Erika mentioned, that there was this anticoagulant came, I think, during that period of time. So it was thought that it could only be stored up to 10 days. And later, with the help of Red Cross Society, at that point, Dr. UN Brahmachari, he was the president of Red Cross Society. He helped to establish a blood depot. Actually, that point of time they used to call it a blood depot, because and it was thought that it should be available in different provinces of the country. So this was a picture which I got with the help of one of our colleague from AIMS Jodhpur, Dr. Mandal. I think this is Dr. Lloyd, I think, encircled in the center. So after that, I think this blood bank was established in 1942 in Kolkata, and small spark of voluntary blood donation began in 54 with the efforts of UN Brahmachari and all. And it gained momentum during Indo-China and Indo-Pak conflicts. And subsequently, in blood bank licensing started somewhere around 1975 with testing for hepatitis B, syphilis, and malaria. And with the introduction of HIV, I think there has been a lot of impetus from the government, and it was made mandatory in 1988, and leading to establishment of National AIDS Control Organization. And blood safety was shifted to blood transfusion services, was shifted to NACO under blood safety division. And these were other milestones in the sense that because of some, I think 3 decades ago, roughly, there was a PIL in Honorable Supreme Court of India, the judgment of which led to formation of various national blood transfusion councils and state transfusion councils to oversee the blood transfusion service in different parts of the country. And licensing was made mandatory in 1997. And professional donors thus were banned in January 1998, and a blood policy came out into existence in 2002. So, and subsequently, other initiatives in the form of hepatitis C testing, starting of blood storage centers in remote areas, to primarily with a focus of helping basically patients with postpartum hemorrhage under Janani Suraksha Yojana of Government of India. And a national plasma policy came into existence in 2014. And later on also, it was thought to do a baseline assessment, which some of part I'll be discussing. And with respect to human resource development, actually, MD program in transfusion medicine started in 1989 in SGPJ Lucknow, and currently there are 70 centers, including ours, providing this degree course in the specialty. So now coming to safe blood, although Arika has already given you an overview, but I think this is a WHO definition that it should be free of these infectious agents, chemicals, or alcohol, or it should not, so that it should not endanger the life of the recipient. So as I see the current dimensions of blood safety are vast, because it is just not collection from the donor and testing it, but it is the decision to transfuse and then finally monitoring and evaluating the clinical outcome. So I take it as a community interface, a laboratory interface, and a clinical interface, starting from the decision to transfuse and finally evaluation of the monitoring and evaluation of the clinical outcome. And these days, the two terms, blood safety and transfusion safety, are used interchangeably, but I think some experts are of the opinion that blood safety, they restrict it to primarily to the product safety, that is the donor screening and regulations as per donor screening. Whereas transfusion safety involves the whole chain. As you saw in the previous presentation, that there are various errors, possibility of various errors which can endanger the safety of the recipient. So these are some of the aspects which I mentioned, like community interface, laboratory and clinical interface, and all these activities have to be done as per in compliance with the regulatory and quality standards in a transfusion service these are challenges. I think this was from the WHO report that primarily in the low and middle income countries, the great challenges of supplies, sufficient supplies, and on top of it, the fragmented blood supply. This is the major challenge, and inadequate trained manpower, inappropriate or inadequate testing, storage, transportation, and insufficient funds and logistics, including the quality systems. So as far as our country is concerned, I think this is for the international audience, that we are a union of 28 states and 8 union territories, 7th largest in area, a diverse geographical terrains. We have hilly in the north, plains, and then we have deserts in the west, and then we have down south, different geographical terrains again. A huge population, I think number 1 in the world, like 1.42 billion, and 65 to 70% in still rural areas. A multi-ethnic and multicultural society with many different languages. So if you look at the health care services in our country, so we have a 3-tier, as our organization is concerned, we have a 3-tier system: primary healthcare, secondary and tertiary healthcare level. And if you look at the management, we have all kind, like in the public health sector, private, and a combination of public and private healthcare. And around 70% of the hospitals are presently in private sector. And if you look at the budget, it's around 2% of the GDP of national health budget. I think where we need to work hard on this. And personally, and in India, an individual has to spend around 42% of population to bear the out-of-pocket expenditure on his health care. And again, the infrastructure varies. I think it is variable from place to place. It can be a substandard facility to the state-of-the-art facilities. Again, the availability and quality of healthcare services is variable. But I think the recent launch of Ayushman Bharat scheme by Government of India has acted as a game changer and significantly improved the access to healthcare facilities by the common man. This is a sort of insurance scheme. And if you look at the blood transfusion services in India, blood is categorized as drug under the Drugs and Cosmetic Act. And there are around more than 4,200 licensed blood banks. This is a big challenge. And out of these, 2/3 are either in NGO, trust or charitable, or in the private sector only 1/3 are in the public sector. And majority of these blood centers are attached to hospitals. And around 20 to 20%, 22% are on standalone. So this is an organogram of our transfusion services that now from NACO, recently for last 2 years, we have shifted onto Directorate General of Health Services, which is under Ministry of Health and Family Welfare again. And we have 2 divisions primarily. This is Blood Transfusion Service Division, and this is a council which guides on the policies and how the services should run. And this looks after logistics and administrative part. And various state blood transfusion councils are again, they look after blood safety and they have a state coordination committees. It has other 2 limbs like Drug Controller General of India, which looks after licensing process of various blood banks. And another is a National Health Mission program, which provide financial and other logistic supports to blood centers in the peripheral, in the different states in the country. These are some blood collection statistics. And there was an assessment by National AIDS Control Organization few years back, and this was published in Indian Journal of Hematology and Blood Transfusion, that with respect to our population, we require somewhere around 14.6 million units, out of which currently we are able to collect 13.6, and thereby a shortfall of around 1 million. And 70% of voluntary blood donation, but this includes family donors also, because this statistics require some sizzling again. And component separation, it is again variable, but on an average it is around 70%. And the TTI reactivity rates are around, I mean, this is highest for in donors basically for hepatitis B, which ranges from 0.2 to 2%. Again for C it's 0.03 to 1.3%. HIV is around 0.14%. So this is depicting the voluntary, basically the blood supplies in different states. So there are some states which have got surplus, there are states which have deficit, and there are certain states which have adequate supplies for their patients. And this is the national average of 70%. And again, the states which have got more than 75% voluntary blood donation, and so on, less than 50%. So again, coming to the transfusion services here, as I mentioned, besides this huge number, but the blood collection varies from, again, it is variable from, say, from 2000 annual collection of 2000, say, to 100,000 units in a year. This is huge variation. And again, the availability, service availability ranges from whole blood to different type of components, and in addition to apheresis also facilities. And the standards from basic to state-of-the-art facilities again, and technologies, manual to fully automated systems, and processing charges, because I think our system is slightly different than the Western countries and maybe different from Australia also. Free of cost in government institutions, most of the government institutions, but differential cost in the costing based on the level of testing and processing in the private sector. And it is estimated that around 30% of patients may not get components when they need it, and 10 to 12% of components get wasted due to expiry because of some or the other reason. So if you look at the availability, this was again from that study. If you look at from the different states in the country, blood banks per million population and annual collection of 100 per 100 population. That is around, if we take one as a one individual, one donation per 100 population. So see, around 14 states, they collect less than 1 per 100 population. And on an average, there are 2.2 blood banks per million, and it varies from 3 blood banks in a state to 400 blood banks. So there is a huge variability. And there are some states which are performing very well, but there are others which are performing below average. So the salient observations were that 25% of the blood bank out of these 4,000 or so collect around 66% of the annual blood volume. and 31% collected more than 5,000. And this is a cause of concern, like 38% collected less than 2,000 units. So these findings, on this basis, the authors they propose that we need to improve upon our voluntary blood donation, optimal componentization, rational demanding, and wise clinical decision, and improve the clinical practices. At the same time, our government is committed because, as you saw, the policy was launched in, I think, 2 decades back. So as per its objectives, they were nicely mentioned, and it has committed to provide safe and adequate blood to its citizens. And to this, they have launched various awareness programs and various awareness programs on voluntary blood donation. And if you see the progression of voluntary blood donation, these were the 3 areas from where this started. Maybe one is in the northern part, it was from Delhi, New Delhi and Chandigarh. In the eastern side, West Bengal. And in the western India, it was from Maharashtra and Gujarat. So in the western India, it was 1954, as I mentioned, that there was a spark by this Mrs. Neela Mulgaonkar. She was inspired by blood needs of her injured son because he had met with an accident but could not be basically saved because of he was not able to provide adequate transfusion support. So then she took up a challenge to basically start this kind of a movement, and later she was appointed as an honorary organizer for blood bank scheme by the government of Maharashtra, and special officer on duty to blood transfusion service of Director General Health Services of India. And likewise in 1962 in Gujarat, Dr. V.G. Malvankar, he initiated this process, and Triguna Sen, it was during the Sino-India conflict. And Triguna Sen, which started this movement, it led to a flame. This spark led to a big flame in the form of Association of Voluntary Blood Donors in West Bengal. And these were 2 from the northern India. This was Dr. M.L. Gupta, who was director Indian Red Cross in New Delhi, and Dr. Jolly, our founder head of the department, who started these voluntary blood donation movements. So these are national averages from this is the data from the ministry. As you see, the national average is around 70%. But as you see here, there are certain states which are still not performing well as far as blood donation, voluntary blood donation is concerned. And these are some of the IEC campaigns, which every year we do it on 14th of June and 1st of October. And so voluntary blood donation, why there has been impetus, I think all of us know, because they are the safest source. And as highlighted previously, the TTI incidence, because the high income countries, they primarily rely on voluntary source. So their prevalence is very low as compared to low and middle income countries. And if you see the TTI markers in our country, these are 2 studies from our northern part of the country, where you see the prevalence of TTIs is around 0.8% in voluntary donors, and it's around 2% in replacement donors. And the nucleic acid testing yield is somewhere around, again, it is low in voluntary donors, whereas it is high, 3 times in replacement donors. So this is, I think, over a decade, the trend of transfusion transmissible infections, because of the government's commitment and improvement in voluntary blood donation, it is declining, but still we need to work hard. But what the challenge is still we are facing is that in different centers, the testing methods are there is a huge variability, basically starting from a rapid testing card to a nucleic acid testing. So in between you have ELISA. Though ELISA testing is mandatory as per Government of India, nucleic acid testing is not mandatory, but all these testing methods are still approved by the Drugs and Cosmetics Act. So, and another important aspect is the post-test notification, because these donors who are tested positive, but as per the national policy, we need to inform them and and tell them their status, and then can be referred further for their as per the infectious marker, they can advise for further medical management. But to to our knowledge, as you look at this review from our country, from 500,000 donors included in these studies, around 7,000 donors were found to be reactive for various markers, and only 1/3 of them reported back. So this is again a huge challenge that we need to work on this, because this is a huge quantum of infectious pool which is there in the community, and which is a risk for their families and community at large. So this was a study from our center also. Now coming to components, actually, national average is around 70 to 75%. It has increased over the years, and different centers are preparing different components. They are available at different centers, and as for requirements, now some of the centers are providing leukoreduced, washed or irradiated and pooled platelets also. And component preparation, as we know, that it helps in appropriate and rational use of blood, and it impacts both availability and blood safety. And as Erica mentioned, that rational use, we can stick to the principles of PBM, that wherever it is not required, we can take help from patient blood management protocols. So if you look at the appropriate use, this is a study which was done at our center with the pediatric emergency department. If you see, and this was an interventional study where we wanted to see how it was utilized, the components are utilized, and after intervention, training the residents, is there any difference? So it was found that around overall utilization of components, I mean, this is an emergency. After ordering, only 50% components were utilized, and poorest utilization was for red cells. So it's a call of the day that we need to sensitize our clinical colleagues that they should not demand if it is not required. So, however, there was improvement. Overall utilization improved after intervention, but it was not statistically significant. Similarly, these studies are from different parts of the country where there is, they voice that there is inappropriate use of blood and blood compounds. So this is another area where we need to work hard. And because these rational practices can reduce the risk of transfusions, prevention of TTIs, minimize these immunological responses, and of course, it will help in cost effectiveness, reduce wastage, prevent preservation of blood inventory as far as blood bankers' point of view, and these can be strategically allocated to patients who are at high clinical need. Now, coming to the thalassemia patients, these especially the multi-transfuse patients. So if you look at the hemoglobinopathies, Southeast Asia is an endemic. And in Indian subcontinent, each year there are 10,000 babies with thalassemia born. And this contributes to the 25% thalassemia burden of the world. If you calculate access to transfusion, if they have an adequate access, 2 units of blood per month, that would utilize more than 50% of our total inventory. So, but in reality, what reports say that they contribute only for 2%. So it is largely an underestimation. So if you see the availability as right quantity in right quality and the right time, and better matched, because these patients over a period of time develop red cell antibodies, and they need special blood products in the form of pre-storage leukoreduced blood, because they frequently develop febrile non-hemolytic transfusion reactions. Again, many of them develop allergic reactions. So many in our institute, we cater to around 350 thalassemic children. Many of them receive washed red cells these days. And then again, with individuals with multiple antibodies, they require some rare types, and at times they require, we need to have some sort of rare donor registry for them. And to meet their requirements, we need to have facility for extended red cell phenotyping, leukoreduction, washing. I think these are available, but at tertiary care settings only. So this is a review from our country only, where you see that there is a aluminization frequency ranging from around 3 to 4% to as high as 10%. and average is around 4.8%. And most common antibody identified was anti-capital E followed by anti-small c. So there is a huge prevalence of aluminization. And now coming to transfusion transmitted infections, this is another challenge. As you see here, overall prevalence varies from 6 to 25, 6 to 50%. So, and it varies from virus to virus, like HCV is the highest, followed by hepatitis B. So this is a review from Southeast Asia, where from the Middle East and other parts of the Southeast Asia, where you see these are the highlighted ones are the Indian studies and other parts of the Middle East. I mean, the scene in those areas is also not very, is not very good, because the incidence is quite high in those parts as well. So I think these are some of the areas where these are directly linked or directly basically affecting these multi-transfused patients. Another aspect is the quality of life. Besides safety and availability, the quality of life, there is a study. This is our Indian study from West Bengal, which published in Asian Journal of Transfusion Science, where they found this high burden of TTIs in these patients have given affected their quality significantly, have a negative impact in terms of physical domain, emotional, social, and school activities. This has affected. So is it? Yeah. So is it so that only HBV or HCV are there? No, but there are other infections also which we have to take care. So as I mentioned that we have a collaborative project with ICMR, and shortly ICMR will come in with a rare donor program registry, and there are some centers which have created a regional program. So this is something about quality management systems. So in our country, national NABH provides, but you see only 3% have got NABH accreditation, whereas there are other certifying agencies like AABB and CAP. So they also, some of the centers have got that. However, overall external EQUAS participation is around 11 to 12%. I mean around 12%. And as far as quality management manpower is concerned, this is around, you see, it is again variable. But yes, people are now becoming aware for their regular maintenance or internal quality. They are looking into, taking care of that. So hemovigilance, I think, as it was highlighted in by the previous speaker, we also have a hemovigilance program. But I think still we need to work hard, because only presently 1,000 centers out of 4,000, only 1,000 are participating. Similarly, in donor hemovigilance, they have enrolled, but still the enrollment is low. Human resource development, I think I touched upon this, that it was started in 89, 70 medical colleges are giving. And I think government of India is taking initiative through information technology, and has created a e-Rakt Kosh portal for the convenience of its citizens, that where you can check up the blood banks stock availability, and if you want to donate blood, you can go for a voluntary blood donation camp. And this is something about pricing, because although this is not concerned with the thalassemia, but this is for the general patients, because for thalassemia, hemophilia, and sickle cell and cancer patients, all public sector institutions, they provide free of cost. Whereas some of the states in the country, they provide free of cost for all type of patients like Punjab, Rajasthan, and Tamil Nadu. So just to summarize the current challenges and possible solutions, I think policy is there. It's very nicely framed, and it has covered all the aspects of transfusion service, but it is ineffectively implemented due to fragmented transfusion service. So we need to work on our organizational structure, regulatory policy and decision making, and funding agencies. They need to work in close coordination, so that whenever a decision is taken, things happen in a time bound manner. And centralization of blood collection and testing services, and we need to convert these small blood centers, which I mentioned, around 38 to 40%, into storage centers. Other resources, yes, I think we need adequate budgets, and innovation and promotion of indigenous kits and equipments, and more introduction of automation to have standardized testing protocols. Then distribution of blood centers and availability, as I mentioned, primarily in urban areas. And difficulties due to poor access and interruption of operations. And in those areas, you have primarily on family and replacement donors. So what we need to do is we need to do geographical mapping of existing blood centers, take steps to bridge the gaps, robust communication and transfusion channels, and promote VNRD. We need to work on more this, and with an emphasis for first-time donors to regular repeat donors. Transfusion transmissible testing, yes, we need to bring about uniformity, help in ensuring quality. This will help us in ensuring quality standards, introduction of better technologies such as nucleic acid testing, and of course, we have to make our pre-donation counseling more robust and basically make donors realize that post-test notification, they must report back, because this is very important area which we need to work hard. We need to augment our component preparation and frame our own guidelines for, and I think the academic institutes must take in a lead, and constructive dialogue. I think these can only happen with a constructive dialogue with our clinical colleagues and work towards PBM and patient blood management. Hemovigilance, yes, we need to work hard on that, and we need to do efforts to create separate cadre of transfusion medicine workforce at all levels, not only at medical officers, but we need to work for technologists, nursing, and counselors. Finally, the quality management systems, yes, we need to work hard on this, that we have to look that they are effectively implemented so that we can bridge this gap, bringing transfusion services closer to the community, because from, as I mentioned, that majority of our population is in rural area still. So we have to we need to create good blood storage centers where I think the large, these tertiary care hospitals can act as a mother blood centers and bring blood closer to the community. So thank you, everyone. Thank you for kind attention and giving me this opportunity to be here. Thank you.
Thank you, sir. Thank you for taking us on a journey from 1924 when we had the first blood center to almost a century of what we have achieved. And yes, we have to work more and achieve more. So yeah, I'll request Shobhatuli ma'am to kindly initiate the discussion.
Yeah, first of all, I would like to thank both the speakers, Dr. Erica Wood and Dr. R.R. Sharma, and for giving the excellent presentations, sharing their experiences and what is the current status globally as well as in India. I have a few questions which I have received. Somehow I know the answers, but I have received it on my WhatsApp group by the parents and the patients who are attending this meeting. So these queries are for both the speakers. So one is that we all are aware about how diverse is our country, hugely populated, and the number of thalassemia major patients is a big number. And we have heard Dr. R.S. Sharma about what is the current status of the blood transfusion services in our country. But what we have seen and what parents are asking is that since the blood transfusion, there's no uniformity in the blood transfusion, even in a single city. That is our experience, what we have seen. In one of the hospitals, they're best of the blood transfusion services. NAT tested blood, deco depleted blood, on demand, no replacement. Whereas in the same city, we see that the whole blood, the packed blood cells is given, and the patients are using the bedside filters. The pre-storage filters are not being used, and they are being asked sometimes to replace the blood. And in some of the states where the blood collection is really at a very poor stage, we have seen that the patients sometimes receiving whole blood as well. And in some states where I found it, that all the patients, irrespective of whether there's a blood reaction, the saline washed blood is given to all the patients, irrespective of knowing whether they need it or they do not need it. So these are my few questions. And another one, that some patients, the hospitals, they say they want to know more about what is the correct age of the blood should be. Should it be 5 days? And they say, or is it, even if it is 15 days, it is good enough to transfuse a thalassemia patients? And another, the last, which is from my side, is that in order to avoid the TTTs, what is your best suggestion, looking at the country as India or for the other countries who are in the same status? What do you suggest? What parents should, and the families and the patients should do from the very beginning to avoid the triple Ts? So there are a lot of questions I have said in a comments in one sentence, I hope. But if you want me to repeat it, I am here to repeat it.
Sir, would you like to take?
I think maybe let us have comments from Erica, then I can maybe let us have her opinion on this. Yeah.
Certainly. It's a great list of questions, and these are questions which are very important and are being asked all over the world where there is inequality in access to safe blood and also other aspects of care. So some of this relates to policy. So policy is very important, as Professor Sharma mentioned in his presentation. WHO can help here in making sure that policy relating to blood transfusion, the messages are reaching the decision makers, the policy makers who have the authority to make change. We also realize that then there are local implementation issues, and that a lot of these relate to funding and access to resources, including skilled technical expertise. You can have all the policies in the world, but if there is no implementation and if there is no evaluation of the policies or evaluation for compliance with policy, then they can be a little bit empty. And so many governments, especially in low and middle income countries, have good policies, but they have little capacity in enforcement of policies. So that often contributes to a wide variation in practice across a country. And my understanding from visiting India and also many discussions with colleagues working in India and patients and families is that the Indian system is extremely diverse, and some of that was shared with us today by yourself and others. So there are some aspects, I guess, of manufacturing related to the availability and quality of the product, and then there are how these are used. It would be nice to have NAT testing and very modern manufacturing processes to make components available to every patient in India, regardless of where they were. That would be true equity. That seems a goal, but a very difficult one to obtain. But I think it would be also true to say that things like NAT testing, they have their place, but they are only one part of ensuring blood safety. So if the donors are low risk and repeat donors, as was mentioned before, this can cause an enormous reduction in risk to the recipient, even without NAT testing, provided sensitive serologic tests are used on every donation. This can also make a big improvement in safety. So the image that I showed from North America, going back to the 1980s, the improvements in safety were about community motivation to donate by low-risk donors, screening health questions prior to donation, implementation of the best available tests at the time. But this was all pre-NAT testing. So there's a lot of work that can still be achieved in improving safety from very basic principles related to low-risk community volunteers. I certainly don't have all the answers. I would say that in many countries, Australia included, we used to have many more blood collection centres and processing centres than we do now. This can be a very difficult diplomatic and operational transition that often takes a long time, but centralisation, harmonisation, alignment of both policies and procedures and inspection of facilities to ensure compliance. These are some important elements that are part of quality management in improving the safety of blood for transfusion. I'll stop there and ask Professor Sharma if you'd like to comment.
Yeah, thank you very much, Erika. I think your comments are very important. And yeah, we basically, as you mentioned, Government of India is working on these directions because policy, yes, we have, but its effective implementation we have in various parts. But since health is a state subject, so at times there is a delay in implementation of the decisions actually which have been taken, and it may take years actually, sometime 5 years, 10 years. I mean, sometimes things doesn't happen. But yes, I think what is Mrs. Tully was concerned, like TTIs. Yes, I agree. There is a high incidence, ma'am, because as you see, the thalassemics today, because the hepatitis C was only made mandatory in 2001. So I think the thalassemics which are more than 20 years of age or 25 years of age, in any case, when it was not there, so they might have already got some units. So this is not a case in our country. It is all over the world actually when the testings were not started, because HCV was only discovered in 1989 and in the late 80s. Yeah, so and the tests they came up in the early part of 90s. So it is all over the world. The challenges which these are being faced by multi-transfuse patients. But yes, what I would recommend is that we need to work on various. There needs to be a multi-pronged approach on this. Yes, one is community front. We have to rely on regular repeat donors, and maybe the thalassemia federation in this can motivate various schools, colleges, and we can always and you can channelize them to come and on a regular basis for blood donation from to the centers from where you are getting blood supplies. That is one thing where you can motivate, and that too on regular basis, because then we need to motivate those donors to be regular repeat donors on repeat basis. That is one aspect. Another is, yes, we need to ask our blood centers to part external quality assurance programs. I understand, because that is an area where we need to basically work, and uniformity of TTI testing, like ELISA. I think although it gives third or fourth generation ELISA, it gives a better, quite a high level of safety. But even if we implement NAT, we cannot do away with ELISA. ELISA will still remain there. So those kind of approach, but yes, from technical point of view, that needs to be done. And as yes, of course, now Government of India is planning to start a centralized testing, NAT testing service in different parts of the country, so that now you get the maximal. I think so far our around only 2 million units are NAT tested, but rest of it is not NAT tested. So so as to provide maximally NAT tested blood to the community. So that is again another aspect. Yeah, so that is another aspect. And the third thing is, what I would see, that because these thalassemic children, they have another important aspect is aluminization, because they are aluminized over the years, because many of the centers did not have this extended phenotyping facility maybe 2 or 3 decades back. Now the new children, if they get an extended better matched blood, so they will be a safer, they will be on the they would be safe. But Yes, the ones who already are aluminized, we can have some dedicated donor kind of program, which again would be voluntary, who are phenotype match donors, and those can again the community can help us in that. So I hope I was able to answer your. Maybe you can repeat your queries. I will answer them again if I'm not
I think
sure.
there is
I
one.
think,
Both
Dr.
of
yeah.
you,
Erica
both
wants
of
to.
you have answered my queries. But one thing which I want to ask you now is especially because you see, we are talking about the safety of blood, which includes, of course, the availability, accessibility, and also the safe blood, which that should be made mandatory for all the blood transfusions, not only for thalassemia, because it's not practical in a blood bank to just segregate the blood for thalassemics and for others. So I want to have your opinion. Should we, because we all know that in India, the health is a state subject, which you have rightly said. So what do you suggest? Should we approach, of course, we are talking with the Union Health Ministry. Should we approach WHO also to make a mandate on this, that there should be uniformity of blood transfusions in all over the country? Should we approach WHO? Do you think that our voice will be heard there?
Yeah, I mean, there is no harm approaching WHO, but as I said, implementation NAT in one go, because NAT is a specialized test, it requires specialized infrastructure and testing facility. So it will not be possible to do it overnight. I think for that, as I mentioned, government of India, I think recent meeting also, there was quite a huge discussion on this, that how do we implement NAT. So we give them an opinion. There are centers in different parts of the country, north, east, west, who has NAT testing facility. So we proposed it that we, rather than making mandatory in every blood bank, we can keep some regional testing facilities, create regional NAT testing facilities where blood can be shipped. This happens in all part different. I like in United States and even in Australia. I think testing and that is being done in a centralized manner. That will be cost effective, and you can ensure your quality management systems there. So that is going to be very helpful. So, because if you make mandatory for every blood bank, then I think out of 4,000, you will be shutting 3,500 blood banks. Only maybe I think I'm really not sure if 500 blood centers are doing it. So
So
that's a
it's not
big challenge. Yeah,
in our country. And
yeah,
what
that's a big challenge.
replacement, the replacement is also a big issue. I think Dr. Erica wants to say
Yeah.
something.
Yeah, Erica, please.
Oh, just to join the discussion. So excellent discussion and great questions. Thank you. I would agree. It's probably not feasible or necessary or desirable for every small blood collecting center to be doing NAT testing. It would be very expensive, and it would be very hard, very difficult to maintain the quality. But a coordinated approach with some centralized testing, in many countries, this already exists for other types of specialist testing, whether it's red cell antibody investigations or other kinds of tests. Not every center does all testing, but they may be coordinated in some hub and spoke or other kind of collaborative arrangement. This can be one way of improving quality for everybody, because if people are doing that kind of arrangement, then everyone has to commit to the quality management systems to achieve the good outcomes. And I agree. I think NAT testing is one part of improving safety. It certainly can help, but it is not the only part. And it is actually a kind of it could give a false reassurance if that is the only thing that people are relying on for blood safety. So I would also like to say a couple of things. Firstly, don't underestimate the power of your voice. The fact that we are having this webinar today and that you are chairing it is so powerful. And I don't mean that to sound insincere, but what I mean is that you already do a lot of advocacy at the highest levels of government, but the stories that governments take, patient stories are very powerful in getting a message across. They don't always translate into action, but they at least raise awareness, and they are a very important starting point. But governments, the things that governments, in my experience, are concerned about, they're concerned about money, which is understandable, and they're concerned about risk. So sometimes framing the discussion, aware of the fact that these kinds of initiatives would cost money, but putting the discussion in the context of risk, the risk that the government continues to incur or run if they don't take action. So the UK infected blood inquiry will cost the UK government a lot of money. And they interviewed former prime ministers, former ministers of health, hundreds, in fact, thousands of people in this inquiry. The consequences of transfusion-transmitted infections have a very long tail for decades, as we have been discussing tonight. So there may be the opportunity to raise the risk issue. Obviously, there's a risk for every individual patient on every occasion, but the risk to government of not taking action may be a powerful message. And you have a wonderful national organization with strong international links. And I think the kind of session we're having today is such a fantastic example of working together to try to improve the situation in India, but these kinds of messages are important all around the world. So thank you for inviting me to be part of it.
Thank you, Dr. Erica. I think there is one raise of hand from Dr. Shailendra Sheesh. If you want to maybe unmute yourself and ask your question.
Good evening, all of us. Good evening.
Yeah.
Hello, sir. May I audible?
Yes, you're very.
I want to ask one question, sir. What is the role of saline wash in blood transfusion?
Sir, do you want to?
Saline wash is basically primarily for those patients who are having frequent allergic reactions, basically. So this is just to get rid of certain plasma proteins which cause uneasiness or some allergic rash or repeated. I mean, these are the patients who get this kind of reactions after transfusion. So this is primarily to take care of those kind of adverse events. Yeah.
तो शर्मा सर, मैं ये पूछ रहा हूँ कि उससे मतलब अगर सलाइन वॉश नहीं किया और रेगुलर अगर देते रहे तो कुछ एडवर्स तो नहीं होगा ना सर?
नहीं, ये देना उसी को है जिसको एलर्जिक रिएक्शन होगा।
ओके सर।
अदरवाइज रेगुलरली सलाइन वॉश नहीं, अदरवाइज तो हम सैगम सस्पेंडेड रेड सेल्स देते हैं। सैगम सस्पेंडेड रेड सेल ल्यूकोरिड्यूस देते हैं। कई जगह ल्यूकोरिड्यूस की नहीं है, बट एटलीस्ट सैगम सस्पेंडेड रेड सेल्स हों, बफी कोड डिप्लीटेड, दे वुड सर्व द गुड पर्पस। या
और सर ये ल्यूकोसाइट रिसेप्टर जो होता है ना फिल्टर, उसका भी इम्पोर्टेंस
है। उसका इम्पोर्टेंस ये है कि अगर तो बेड साइड लगाते हैं वो इतना काम तो करेगा, बट आई थिंक अगर स्टोरेज फ्री स्टोरेज अगर ब्लड बैंक में ल्यूको रिडक्शन हो जाए तो ज्यादा अच्छी बात है। इट इज बेटर टू
सर
ज्यादा बढ़िया है।
सर एक वन मोर क्वेश्चन सर, लास्ट सर, वो फिल्टर की अवेलेबिलिटी का थोड़ा इश्यू हो सर, कुछ हो सकता है उसका, मतलब थोड़ा इजीली अवेलेबल हो पाए?
फिल्टर की अवेलेबिलिटी का आई थिंक मे बी एटलीस्ट वो तो देखो आपके लोकल जो वेंडर्स हैं वहां पे, लोकल सप्लायर्स हैं, उनके थ्रू आप अपनी वॉइस रेज कर सकते हो। अपने जो वहां के लोकल आपके ऑर्गेनाइजर्स हैं या लोकल मिनिस्टर हैं या लोकल जो ड्रग कंट्रोलर एजेंसीज हैं, आप उनसे कांटेक्ट करके दे कैन हेल्प यू, वो आपको हेल्प कर सकते हैं।
अगर आप खरीदना चाहते हैं तो आप थैलेसीमिया को कांटेक्ट कर लीजिए।
हाँ, मे बी मिसेस तुल्ली को। या
है,
can I get contact details for that?
I will share it on this group only.
Okay ma'am, thank you. It may be very good, helpful for us, our community.
Okay.
Thank you madam. Thank you.
Thank you. So I think yes, as we thought of this webinar, we have more questions to answer than answers to a question, which we thought the topic is of that type. And I would like to take this opportunity to thank Dr. Erica for finding time, agreeing to our invite, and being available. Thank you, ma'am. I know it's very late,
A
and
pleasure. Thank you for the invitation. Nice to meet you all.
thank you. And Sharma sir, thank you. We keep
Thank you.
disturbing you and keep having you in our various programs, and you always
Most,
consent and you always guide and mentor us. Thank you, sir.
most
Satyam,
welcome. Most
yeah,
welcome.
I would
And
like to say a few more words
yes, ma'am.
to wind it up. So first of all, of course, thanks to Dr. Erika and thanks to Dr. R.R. Sharma, and of course to the co-hosts, Dr. Neeta Radhakrishnan and Satyam Arora as well, and to all those who joined us today from various parts of the country. But I would like to confirm it here, and I would like to say that, well, our government, in spite of the health being the state subject, the union government has been very, very helpful. We have the guidelines in our country which are going into the revision mode by, I think there will be the latest revision will be done by early next year. So all the parameters are there. Just because of the numbers are huge and because of the diversity of our country, so we are not in India, we are not able to, to offer the uniform kind of blood transfusion services in our country. But as everyone is here, so I want to just say that, well, we have done a lot, we have achieved a lot living in a country like this, but of course there are many gaps and many challenges. But I want to tell you that I was in a meeting in one of the most advanced country, I don't want to name, and there were about 30 participants from all over the world, and we were talking about blood safety, we were talking about the blood accessibility and the availability. And the common point which I picked up from there was that each country was talking about the shortage of blood. So first of all, in a country like big country like India, we have to see collectively that how we can, address this problem challenge. And there are some NGOs, people who are sitting here, even from Chandrakantji is here and from the other societies. All the thalassemia NGOs are really putting in a lot of their efforts and work in making sure in holding the camps on time so that there is no shortage of blood. We agree that, well, there are still challenges, still gaps, but if we all work together as a team, having the expertise from abroad, I think we can move ahead and we can meet our goals. That's all I just wanted to say in the end. Satyam, if you want to add anything
Thank you,
about
ma'am.
next webinar, you can announce.
Yes, yes, ma'am. Thank you for supporting our webinar, ma'am, and being available for the same. So, as a concluding remark, I would like to thank the ECHO team also for providing us this logistic support of online, connecting people across the world, and Dr. Neeta Radhakrishnan for actually conceptualizing these webinar series. As from blood, we'll move ahead to a lot of clinical discussions. For next webinar, we will be discussing aluminization in our thalassemia patients, which will be on 25th of January. So we will advertise and we will share flyers for that soon. And thank you again. Thank you again, Dr. Erika, Dr. Sharma, Shobatuli ma'am, for being with us today in the evening and sparing time. Thank you, everyone.
Thank you. Thank you. Thanks a lot. Thanks.
Thank you,
Bye.
everyone.
Thank you. Bye.
Bye. Bye. Thank you. Have a nice day.
Bye.
Bye bye. Thank you.